مساء الخير. Our subject today is high-risk breast lesion, role of multi-parametric dynamic contrast enhanced MRI in detection and histopathological upgrade prediction. Our discussion today will be depending on three main points. What are high-risk breast lesions, management of high-risk breast lesions, and MRI assessment of high-risk breast lesions. High-risk breast regions are regions that carry increased risk for future development of breast cancer or carry suspicious of a more sinister pathology around or in association with the lesion. It includes lobar neoplasm, atypical intraductal epithelial proliferation, papillary lesions, and radial scar. They are lesions with uncertain malignancy. That's because they are non-obligate precursors of malignancy. They can develop into high-grade lesions, and they also function as a risk indicator. They have disparate imaging features. The problem is up to 35% of lesions of uncertain malignant potential are subsequently upgraded at surgical specimen to ductal carcinoma in situ or low-grade carcinoma. The risk of missing a malignant component associated with a high-risk breast lesion at image-guided biopsy varies from 2 to 58%. According to recent guidelines, high-risk lesions may be managed with imaging follow-up, vacuum-assisted excision, or open excision. Management depends on MDT assessment to find a tailored management, a lesion-specific therapy approach. Our main aim is to be able to detect high-risk lesions that are more susceptible to surgical upgrade. Dynamic contrast enhanced MRI study usually contain T1 weighted imaging, T2 weighted imaging and STAIR, diffusion weighted imaging and ADC mapping, and dynamic study with curves. We assess value of dynamic contrast enhanced MRI, including diffusion weighted imaging and ADC mapping in the detection of high-risk breast lesions, differentiating them from malignant lesions and predicting upgrade risk after surgical excision, reducing misdiagnosis and overtreatment. Our study is a retrospective review of all image-guided breast biopsy procedure performed at 2021 at our institute. We identified 85 patients with histopathologically proven high-risk breast lesion. Out of those, 68 patients had MRI assessment and no concurrent ipsilateral malignancies. The most common detected high-risk breast lesion in this population was papillary lesions. By comparing ATC value of 150 benign breast changes, 68 high-risk breast lesions, and 150 malignant breast lesions, the cutoff ADC value for detecting high-risk breast lesion from benign breast lesion was 1.5, and the cutoff average ADC value for differentiating malignant breast lesion from high-risk breast lesion proven to be 1.3. Example of our cases: 45 years old patient with strong family history, showing multiple bilateral complex cystic lesion on sonomammographic assessment. Dynamic contrast enhanced MRI revealed bilateral cystic lesions with intralesional soft tissue component. The intralesional soft tissue component elicit mass enhancement showing type 2 curve and ATC value of 1.23. Ultrasound-guided VAB-assisted excision revealed intraductal papilloma, UDH, and ADH. Surgical excision revealed low-grade ductal carcinoma in situ. Cutoff average ADC value for differentiating upgraded high-risk breast lesion from non-upgraded high-risk breast lesion proved to be 1.24, with sensitivity and specificity of 94 and 100% respectively. Another example: 35 years old patient with palpable breast lesion, sonomammographic assessment revealed right breast upper outer quadrant asymmetry with underlying parenchymal distortion. Dynamic contrast enhanced MRI revealed right breast upper outer quadrant focal segmental high stir signal, showing non-mass enhancement and type 3 curve, and ATC value of 1.28. In this study, non-mass enhancement and type 3 enhancing curve proved to be significant indicator of high-risk breast lesion upgrade in surgical pathology. Our knowledge about high-risk breast lesion is increasing. Radiological pathological correlation in MDT is the essence of management pathway, aiming to develop a lesion-specific tailored therapy approach. MRI is a diagnostic tool to detect and predict upgrade risk of high-risk breast lesions. For discordant regions, a repeat VAP and/or a diagnostic excision may be required. Thank you.
Thank you, Dr. Samar. Good evening, everybody. Good afternoon. Okay. Next speaker is Dr. Lubna Khalid. She will give us a talk about imaging features of the molecular subtypes of breast cancer.
هو مش بيعرض على الشاشة. مساء الخير جميعا. Imaging features of the molecular subtypes of breast cancer. Breast cancer is a heterogeneous disease, comprises several molecular and genetic subtypes, each with characteristic clinical biological behavior and imaging patterns. Previously, breast cancer management was depending on different schemes, namely histopathological subtypes, either in situ carcinoma or invasive carcinoma, grading according to tumor differentiation, staging according to tumor size, lymph node status, and distant metastasis. But these schemes don't provide sufficient information for specific therapy, accurate prognosis, and survival outcomes. In the past 2 decades, this classification has been enriched by the development in the field of molecular biology, resulting in molecular subtypes. According to gene expression profiling, breast cancer has been classified into different molecular subtypes, including luminal A, luminal B, HER2-enriched, and basal-like tumors. Each subtype has a varied prognosis, risk of prognosis, response to treatment, and survival outcomes. This is a cut section أنا عايز أرجع تاني. This is a cut section of the duct showing inner lining biluminal cells surrounded by basal-like cells. More generally, when the tumor show criteria similar to the luminal cells, they are categorized as luminal cancers, while when the tumors show criteria similar to the basal cells, they are categorized as basal-like cancers. To understand these molecular subtypes, we have to know what's called receptor states. Receptors in the breast, including estrogen, progesterone, and HER2. Receptors are proteins present on the surface of the cell. They bind to the hormones like LOX and key, then telling the cell to grow and divide. Receptors are present on the surface on all breast cells, but they are present in much greater number in cancer cells. So the goal of the treatment is to stop the binding of the receptor to the hormones by blocking these receptors. So in cases of estrogen and progesterone positive cancers, we use hormonal therapy to block these receptors. While in HER2-enriched breast cancer, we use Herceptin to block these receptors. In triple-negative breast cancer, which didn't show any receptors, the only option is the chemotherapy. Based on receptor status, proliferation rate, and other markers of positivity, breast cancer has been classified into 4 major subtypes: luminal A, luminal B, HER2-enriched, and triple-negative. Major criteria of the molecular subtypes of the breast cancer In luminal A subtype, there is overexpression of estrogen and progesterone, no expression of HER2. Proliferative rate is low. Recommended therapy is hormonal. Prognosis is favorable. In luminal B subtype, there is overexpression of luminal B, but less than luminal A subtype. HER2 receptors may be overexpressed. Proliferative rate is intermediate. Recommended therapy is hormonal and chemotherapy. Prognosis is unfavorable. In HER2 enriched, there is overexpression of the HER2 receptors, no expression of ER or BR. Proliferative rate is high. Recommended therapy, Herceptin and chemotherapy. Prognosis is poor. In triple negative, no expression of any of these receptors. Proliferative rate is very high. The only option of treatment is chemotherapy. Prognosis is the worst. Genetic subtyping of DCIS is not as advanced as that for invasive cancer, but the results of biomarkers studies suggest that majority of DCIS tumors express estrogen and progesterone receptors. HER2 expression may be more frequent in high-grade DCIS. Triple negative subtype is infrequent, but is predictive, if present, is predictive of high-grade tumors. Imaging features of the molecular subtypes. First one is a triple negative breast cancer, which is proxy of basal-like subtype, usually presented as unifocal mass, unifocal circumscribed mass. There is usually absence of microcalcifications. This is denoting rapid malignant transformation with bypassing the stage, the in situ stage. In ultrasound, usually presented with circumscribed mass with posterior acoustic enhancement, denoting intratumoral necrosis. 70% of these tumors occurring in BRCA1 mutated women. In MRI, there is characteristic REM enhancement and post-contrast series, bright internal signal in T2 weighted images with a high ADC value compared to other types, denoting intratumoral necrosis. Absence of non-mass enhancement in these cases correlates with the rarity of DCIS. First case, mammography showing obscured mass in the upper inner quadrant of the left breast. In ultrasound, there is corresponding circumscribed hypoechoic mass with posterior acoustic enhancement. In MRI, the lesion or the mass eliciting intermediate signal in T2 weighted images and bright signal instead with REM enhancement on post-contrast series. Next case, showing mammography showing multiple bilateral circumscribed mass apart from one in the left upper outer quadrant. This is corresponding to suspicious lesion in AI. In ultrasound, there is corresponding complex, rather circumscribed complex cystic lesion with ipsilateral pathological axillary lymph node. In MRI, the lesion eliciting internal bright signal in T2 and REM enhancement in post-contrast series with high ADC value denoting intratumoral necrosis. In positron emission mammography, the mass showing intense REM uptake. Next type, HER2 positive breast cancer, proxy of HER2 enriched subtype. They are usually presented by irregular mass almost associated with suspicious microcalcifications. Multifocality, multicentricity, and lymph nodes involvement are common in this type. In MRI, usually presented by heterogeneous mass enhancement. Also, other studies reported non-mass enhancement as a significant presentation. In this case, there is left breast inner quadrant focal asymmetry is seen harboring segmental pleomorphic microcalcifications in mammography with corresponding altered parenchymal echogenicity in ultrasound. Next case showing mammography showing multiple L-defined regular and obscured masses, usually involving the upper quadrants of the right breast. In contrast mammography, there is heterogeneous enhancement of these heterogeneous mass enhancement of these lesions with intervening non-mass enhancement. Ultrasound revealed corresponding irregular hypoechoic masses with ipsilateral pathological axillary lymph nodes. ER positive HER2 negative breast cancer. This is a proxy of luminal A and luminal B subtypes. Usually this type presented by speculated mass. This is more common in laminal A. Architectural distortion more common in laminal B subtype. Also multifocality, multicentricity, and lymph nodes involvement are more common in laminal B subtype. Carcinoma with BRCA2 mutations usually of laminal B subtype. In MRI, this is usually presented by heterogeneous mass enhancement, presence of non-mass enhancement, usually due to associated DCIS. In this case, there is upper outer quadrant, L-defined mass is noted in the right breast, with corresponding irregular or speculated hypoechoic mass in ultrasound. In MRI, the mass eliciting low signal in T2 weighted images with heterogeneous post-contrast enhancement. Another case showing contrast mammography, showing multiple heterogeneously enhancing masses are noted mainly at the upper quadrants of the left breast. An ultrasound corresponding irregular hypoechoic masses are noted along with ipsilateral pathological axillary lymph nodes. Another case showing irregular mass in the outer quadrant of the right breast with in mammography with corresponding irregular hypoechoic mass with internal vascularity on color Doppler and the ipsilateral pathological axillary lymph node in ultrasound. In MRI, the mass eliciting heterogeneous post-contrast enhancement with ipsilateral pathological axillary lymph node is noted. Improvements in understanding the molecular subtypes of breast cancer have paralleled improved personalized treatment options and survival rates for patients. We can also predict the probability of disease recurrence and overall prognosis. Each subtype displays unique imaging features, circumscribed tumors with posterior acoustic enhancement, MRI post-contrast REM enhancement, internal bright T2 signal, and high EDC value are predicted to be of triple negative subtype. Tumors with suspicious microcalcifications predicted to be of HER2 enriched subtype. Tumors with speculated margins and or architectural distortion are predicted to be of laminal subtypes. Multifocality, multicentricity, and lymph nodes involvement are more common in laminal B and HER2 enriched subtypes. Thank you.
Thank you, Dr. Lubna. Next speaker, Dr. Shrihan Fakhri, lecturer of Diagnostic Radiology Breast Imaging Unit, Al-Qasr Al-Aini, and she will talk about papillary lesions of the breast.
Good afternoon. My lecture today is about papillary lesions of the breast, and I'll start by three case scenarios. The first case is about a 62-year female patient with right-sided bleeding per nipple. A mammography showed right breast focal asymmetry with underlying intraductal echogenic content on complementary ultrasound. By contrast enhanced mammography, there was a segmental non-mass enhancement. There was no malignant cells by cytology, and pathology revealed intraductal papillomas. The other case is about a 38-year female patient with left breast lump. Mammography showed left breast circumscribed mass lesion. By ultrasound, there was a complex solid cystic lesion that shows heterogeneous enhancement in contrast-enhanced images. Pathology revealed encapsulated papillary carcinoma. The third case is about a 34-year female patient with left breast lump. mammography showed left breast irregular speculated mass lesion associated with diffuse skin thickening and pathological axillary lymph node. Magnified images showed calcification within the mass and within the axillary lymph node. By complementary ultrasound, there was irregular hypoechoic mass with evident increased vascularity and pathological axillary lymph node. By contrast-enhanced images, there was irregular heterogeneously enhancing mass associated with non-mass enhancement. Pathology revealed invasive micropapillary carcinoma. So 3 different lesions with 3 different pathologies, but they are all categorized as papillary breast lesion with different management options. In the first case, major duct excision was done. And in the second case, wide local excision with sentinel lymph node biopsy was done. And in the third case, conservative breast surgery with axillary lymph node dissection was done. So what are papillary breast lesions? They are a heterogeneous group of diseases characterized by the presence of epithelial proliferation supported by fibrovascular cores. And they have common features, which is the attachment to the wall of the ducts, the extension into the duct lumen, the presence of the fibrovascular core, lesion featuring small papillary-like projection with the lack of fibrovascular core, termed micropapillary carcinoma. They are rare tumor, representing less than 3% of all breast tumor, less than 10% of all benign lesion, and less than 2% of all malignant lesion. But they have a good prognosis. They include a broad spectrum of benign lesion, like intraductal papillomas and papillomatosis, atypical lesion, like papilloma with atypia or DCIS, malignant lesions, which may be non-invasive, like encapsulated, like papillary DCIS, encapsulated papillary carcinoma or solid papillary carcinoma, or invasive, like invasive papillary carcinoma, invasive micropapillary carcinoma, or encapsulated or solid papillary carcinoma with invasive component. There are different classification of papillary lesions, either based on the location in the duct system, or according to the nature of the proliferating epithelial cells, or based on the presence and the location of myoepithelial cells, or the morphology. Based on the location in the duct system, they are either located within a large duct, like papilloma, encapsulated or solid papillary carcinoma, or within the terminal ductal lobular unit, like papillomatosis or papillary DCIS. Based on the nature of the epithelial, of the proliferating epithelial cells, they are either hyperplastic, like papilloma, or neoplastic, like papillary carcinoma, or a mix between hyperplastic and neoplastic cells, like papilloma with atypia. Considering the presence and the location of myoepithelial cells, the absence of an intact myoepithelial cell layer within the papillary structures is an important marker for malignant lesions. Accordingly, and based on these facts, benign lesion can be differentiated from malignant papillary lesions, and specific types of malignant papillary lesion can be distinguished. According to the morphology of papillary carcinoma, there are specific subtypes that may present with well-circumscribed margin, and this poses a diagnostic challenge from the radiological and the pathological point of view, as there might be overlapping morphological features between benign, atypical, and malignant papillary lesions. There might be a difficulty in the diagnosis and classification of certain papillary lesion, and also in the differentiation between the non-invasive and invasive subtypes. Accordingly, the management of papillary breast lesion requires the effort of a multidisciplinary team to achieve proper diagnosis and proper management. So what is the radiologist's role in the diagnosis? He has to identify the lesion in its location, spot the suspicious criteria, especially in those subtypes that can mimic benign lesion, assess the extent of the pathology, guide the tissue diagnosis, follow up of diagnosed benign lesion, and he must have the knowledge about the imaging features of different subtypes. So starting by benign and atypical papillary breast lesions, first, intraductal papilloma. They arise from large central duct, and they are more common in perimenopausal women. Usually they present with pathological nipple suture. They may be seen in mammography as rounded or ovoid, well-circumscribed retroareolar mass, by ultrasound as solid mural nodule within a dilated duct or intracystic mass or hypoechoic solid mass, and color Doppler may reveal a vascular pedicle within the intraductal nodule. In this case, we can see the mammography showed a retroareolar circumscribed lesion. By ultrasound, there was a cystic mass with turbid content and echogenic nodule. Post-operative pathology revealed ductectasia with papilloma. Another case, we can see a left breast circumscribed lesion. By ultrasound, there was a complex cystic lesion with dependent echogenic content that showed enhancement on the contrast-enhanced images. Post-operative pathology was intraductal papilloma. Concerning papillomatosis, they usually are peripheral, arising from the terminal ductal lobular unit, usually affect younger age group, and they are usually clinically occult or rarely present by a palpable mass. By mammography and ultrasound, they are similar to central papilloma, differing only in the location. And the MRI can play a key role in the preoperative planning for patients with multiple nodular lesions to assess the extent of the disease. It should be noted that multiple papillomas are more likely to be associated with high-risk lesions or malignancies compared with a central papilloma. In this case, mammography showed left breast retroareolar and deeply seated focal asymmetries. By ultrasound, there was intraductal echogenic content. By contrast-enhanced mammography, there were multiple enhancing nodules. Post-operative pathology revealed intraductal papillomas with no atypia or malignancy. Concerning papilloma with atypia or DCIS, this entity describes a neoplastic populations of cell within a papilloma, associated with evident increased risk of cancer. Atypical papilloma may have similar feature to benign papilloma. The presence of calcification may suggest atypia or DCIS. Diagnosis is by histopathology. Surgical excision is required when an atypical papillary lesion is present on core biopsy, as there is up to 80% reported upstage to neoplasia. Here comes the dilemma whether to excise benign intraductal papilloma or not. It was found that the frequency of post-surgical excision upstaging of a benign papilloma ranges from 0 to 20%. Some authors recommended the complete removal of papilloma due to the sampling error within the core biopsy and the variability in the distribution of atypia or carcinoma, while other authors recommended the close clinical and radiological surveillance, especially in asymptomatic patient or with imaging pathology concordance. And they assumed that the risk of understaging may be decreased if multiple core biopsy was taken or by using VAB needles. So according to several studies, upgrading of intraductal papilloma to malignancy may be associated with palpable lesions, large lesion size, older age, peripheral lesion, higher BI-RADS score, pathological radiological discordance. In these cases, surgical excision is recommended. In this case, mammography showed right breast focal asymmetry with underlying dilated duct and intraductal echogenic content by complementary ultrasound, and post-operative and core biopsy revealed atypical intraductal papillomas, which was upstaged after surgical excision to multifocal invasive carcinoma with major DCIS. So what about the malignant papillary breast lesions? Generally, they are more common in postmenopausal females, and they are either non-invasive or invasive. Starting with papillary DCIS, it is a variant from DCIS, associated with higher rates of multicentricity, microinvasion, and higher recurrence rate after excision compared to other DCIS variants. And this may be due to the extensive ductal spread and underestimation of the non-calcified part of the DCIS, which may make it difficult to obtain clear margin after excision. So it should be noted that on mammography, micropapillary DCIS may present as pleomorphic calcification in only a portion of the lesion. Thus, it may extend beyond the zone of mammographically detected suspicious microcalcification. It may be occult by imaging or present on mammography as pleomorphic calcification or architectural distortion, by ultrasound as ill-defined hypoechoic mass or calcification, by MRI as non-mass enhancement. In this case, mammography showed left breast focal asymmetry with architectural distortion. By ultrasound, we can see a conglomerate ductal dilatation with intraductal echogenic contents. By contrast-enhanced mammography, there was a segmental non-mass enhancement. Post-operative pathology revealed atypical intraductal papillomas associated with papillary DCIS. Considering the encapsulated papillary carcinoma, it is a carcinoma within a cystically dilated duct. Frequently, they are solitary and centrally located within a duct. They are typically a disease of postmenopausal women, and they are the second most common breast malignancy in males. Can present as palpable, painless breast lump or pathological nipple discharge. By mammography, they may appear as round or oval circumscribed solitary mass, may be associated with microcalcification. By ultrasound, usually as a complex solid cystic mass or a hypoechoic solid mass. By MRI as enhancing nodular lesion or enhancing complex cyst. Encapsulated papillary carcinoma tends to bleed centrally. Color Doppler sonography can show blood flow in the tumors and aid their differentiation from blood clots. Yet, in the elderly patient with large turbid cyst and echogenic soft tissue-like component, even with no depicted vascularity, it's better to perform aspiration. The presence of a bloody aspirate or rapid refilling after aspiration is considered a suspicious feature. Also, it's important to include the wall of the mass in biopsy samples to distinguish encapsulated papillary carcinoma, which lack the myoepithelial markers, from an atypical papillary lesion. In this case, mammography showed the left breast circumscribed hyperdense mass. By ultrasound, a complex solid cystic lesion was detected, and postoperative pathology revealed encapsulated papillary carcinoma. Another case, right breast, mammography showed right breast retroareolar hyperdense mass with indistinct margin. By ultrasound, there was a circumscribed solid lesion with a cyst-like cleft resembling phylloides. Yet, by contrast-enhanced mammography, there was intense heterogeneous enhancement, and post-operative pathology revealed encapsulated papillary carcinoma with associated DCIS. There was no invasion. Follow-up of this case, there was a newly developed cluster of microcalcification on the left side that showed nodular and linear non-mass enhancement on MRI, and the pathology revealed intermediate grade papillary DCIS. Concerning the solid papillary carcinoma, this is a rare entity that is composed of low-grade tumors that originate in large dilated ducts. Mammographically, it is usually seen as rounded oval circumscribed mass, and similar to encapsulated papillary carcinoma, it is considered in situ carcinoma despite the lack of peripheral myoepithelial cells. They rarely metastasize and are associated with excellent prognosis. In this case, mammography showed left breast hyperdense mass with indistinct margin, and by ultrasound, there was an intraductal mass with increased vascularity, and postoperative pathology revealed solid papillary carcinoma with no invasion. In encapsulated solid papillary carcinoma associated with invasive component, they are staged according to the size of the invasive component. So please don't upgrade the stage of the tumor based on the mammographically measured size. In this case, mammography showed left breast circumscribed mass with partial obscured margin. And by ultrasound, there was circumscribed hypoechoic lesion that showed rather homogeneous enhancement on contrast mammography, yet focal linear non-mass enhancement was noted. So pathology revealed encapsulated papillary carcinoma with the stromal microinvasive component and associated DCIS. Pure encapsulated or solid papillary carcinoma are considered in situ disease. They may be associated with DCIS or invasive cancer around the periphery of the tumor. They rarely show speculation. The presence of focal irregularity or speculation should raise the suspicion of invasive component or associated invasive carcinoma. As in this case, here mammography showed an irregular hyperdense mass with a partial circumscribed margin and a speculated component associated with the skin thickening and dimpling. That was confirmed by complementary ultrasound, and by contrast mammography, there was a marginally enhancing cystic lesion with an intensely enhancing speculated component. Postoperative pathology revealed invasive ductal carcinoma associated with encapsulated papillary carcinoma. Concerning invasive papillary carcinoma, they are characterized by having papillary architecture in more than 90% of the invasive tumor. They have a better prognosis with less axillary nodal involvement than do other forms of ductal carcinoma. By mammography, they may appear as nodular densities, which may be multiple, and calcification are not usually evident. By ultrasound, they are hypoechoic and irregular. Encapsulated and solid papillary carcinoma shouldn't be classified as invasive papillary carcinoma, and they should be categorized according to the individual invasive component. In this case, mammography showed a circumscribed lesion with indistinct margin. By ultrasound, we can see an irregular hypoechoic lesion with a microlobulated margin and angular margin. And the postoperative pathology revealed invasive papillary carcinoma. Another case, the left breast, there was a right breast speculated hyperdense mass lesion associated with areolar skin thickening, and left breast lobulated equal density lesion. By ultrasound, the right mass showed indistinct margin and the left mass was irregular and hypoechoic. By contrast enhanced imaging, they showed bilateral enhancing lesions. The postoperative pathology revealed right invasive ductal carcinoma and left invasive papillary carcinoma. Lastly, the invasive micropapillary carcinoma, they are aggressive variant of invasive carcinoma and usually associated with axillary lymph node metastasis and lymphovascular invasion. By mammography and ultrasound, they usually appear as irregular mass with the speculated margins, and associated calcification are common. By MRI, as irregular mass with washout kinetics, or may present as diffuse heterogeneous non-mass-like enhancement. In this case, mammography showed this tiny lesion with speculated margin as revealed by the magnified images. By ultrasound, we can see an irregular hypoechoic lesion that showed enhancement on the contrast-enhanced images. Postoperative pathology revealed invasive micropapillary carcinoma. So, finally, our take-home messages. The classification and morphological imaging characteristics of papillary lesions remain challenging for pathologists and radiologists. Central solitary papilloma is usually benign and can be followed up, but if core biopsy revealed atypia, surgical excision is recommended to avoid understaging. Encapsulated and solid papillary carcinoma rarely metastasize, yet if associated with invasive component, axillary lymph node assessment with sentinel lymph node biopsy is recommended. Invasive micropapillary carcinoma is an aggressive variant and is associated with poor prognosis. Though imaging can help to differentiate the forms of papillary lesion, but surgical specimens are required for definitive diagnosis in the majority of cases. Thank you.
Thank you, Dr. Sherihan, for this very interesting lecture. Now we'd like to present Dr. Iman Hosni, who is a breast imaging eminent radiologist. She works in Bahia Cancer Hospital, and we're looking forward to hear her lecture on multimodality screening of high-risk individuals.
Okay. Thank you, Doctor. Good evening, everyone. Thank you so much, Dr. Nuran.
Today we will be talking about the multimodality screening of high-risk individuals. Next. First of all, we will talk about simple breast cancer facts and figure. The last statistics denoted that 1 in 8 women will be diagnosed with breast cancer at some time during her lifetime. In the United States, the estimated 2.9% of the women born in the United States today will develop breast cancer at some time during her life. In 2021, last statistics, they said that breast cancer has overtaken lung cancer to be the world's most common diagnosed cancer. Since 1989, there was a decline in the breast cancer mortality rate by 42%. In March 8, 2020, the WHO declared that the breast cancer is a global issue, and they initiated the Global Breast Cancer Initiative, aiming to reduce the mortality rate by 2.5% till 2040. That's why, because the inequity in the breast cancer death among high-income countries and low-income countries. For example, in the high-income countries, 9 out of women will survive breast cancer when they are diagnosed, while in India, 6 out of 10, South Africa is less and less. Screening age, methods, and interval. Average risk women, there are women with a risk of developing breast cancer less than 15% lifetime. The age. The majority of guidelines recommended mammographic screening aging from 40 to 74, with the main optimal age for screening from 50 to 69. No upper age limit to stop breast cancer screening. The age to end the screening should be determined based on the woman's health status. For example, stopping screening for women with life expectancy lower than 5 to 7 years or 10 years. Methods and the interval for screening. Mammography was recommended as the primary screening modality for average risk women. Most guidelines suggested annual or biannual mammographic screening. Clinical breast exam and ultrasound suggested by some of the guidelines, but did not recommend the clinical breast examination as the primary screening method. Only National Cancer Center of China recommended screening every 1 to 2 years for women older than 45 by ultrasound alone. All guidelines did not recommend breast self-exam or magnetic resonance MRI for average risk women. Screening for women with a higher than average risk. They are 10 to 20% lifetime risk of developing breast cancer. They are women with personal history of precancerous lesion and or breast cancer. For women with a biopsy-proven lobular carcinoma in situ, atypical ductal hyperplasia, ductal carcinoma in situ, invasive breast cancer or ovarian cancer, annual mammography or annual MRI was mainly recommended after diagnosis onward, and they are concerned about the contralateral breast if it's unilateral invasive cancer. Women with family history of breast cancer, the degree of relation, first degree relative or greater, number of relatives, age at diagnosis, age at onset of breast cancer diagnosis, unilateral versus bilateral disease. The guidelines recommend that the annual mammogram and the annual MRI begin 10 years before the age of diagnosis of the youngest affected relative, but not before the age of 30. Women with history of mental or chest radiation therapy, like in Hodgkin lymphoma, chest radiation therapy that occurred before the age of 30 with a cumulative dose of 10 gray radiation, starting regular screening 10 or 8 to 10 years after radiation therapy, annual mammogram not before age of 30, and MRI not before age of 25. Women with non-genetic predisposition of breast cancer, women with breast cancer susceptibility, BRCA1, BRCA2 mutation, or untested but have a first-degree relative, mother, sister, or daughter with a proven mutation, have a higher risk of breast cancer, should start to undertake annual mammogram or annual MRI at 25 to 30 years. Mammogram and digital tomosynthesis is recommended when MRI is not tolerated. Women with dense breast density as an independent risk factor for development of breast cancer, decrease the sensitivity of mammography for screening, increase the risk of developing breast cancer with approximately twice as high as for women with an average woman, and almost 4 to 6 times as high in women with almost entirely fatty breast. The recent ESOBI, European Society of Breast Imaging guidelines recommend MRI should be performed annually. The value of different modality in breast cancer screening of high-risk women. Let's start with the digital tomosynthesis, digital breast tomosynthesis. Increase the overall cancer detection rate and decrease the recall rate, leading to more favorable sensitivity and specificity. Among women with extremely dense breast at high risk of developing breast cancer, digital tomosynthesis compared to the mammography alone can be associating of lower risk of advanced cancer. Case number 1, 57-year-old female coming for screening. She has a positive family history, first degree relative, her sister at age of 50. Screening revealed ECRD, extremely dense breast. This was the baseline screening in 2021. She was given a bilateral fibrocystic change by RADS2. Routine screening study 2022 showed area of parenchymal distortion depicted in CC view. Additional tomo revealed the speculated mass, and the result was invasive ductal carcinoma. The AI detected with 66% probability of suspicious, and this is the slice of the tomosynthesis delineating the speculated mass within the heterogeneous, extremely dense breast. This is the ultrasound of the study, and the contrast mammography demonstrate a solitary enhancing lesion. 64-year-old lady, ECRC, heterogeneous dense mammary parenchyma, on baseline screening 2019 showed bilateral fibroadenosis and bilateral benign calcification. Routine screening in 2022 showed newly developed asymmetry depicted in the MLO view. Additional tomo revealed the speculated lesion. A deeply seated asymmetry appreciated more in the MLO view, and in the tomosynthesis, it's a speculated mass at the outer quadrant. And by contrast mammography, there was a nodular background parenchymal enhancement in addition to a focal area of non-mass enhancement of suspicious. 74-year-old lady with extremely dense breast. This case actually was a missed cancer. The baseline screening done in June 2022, they showed a right breast fibroadenoma and reported as BIRAT3. The patient came after for 6-month follow-up by ultrasound. Ultrasound depicted an irregular mass lesion, deeply hypoechoic, in the zone B, in the breast. We try to have a tomosynthesis, additional tomosynthesis. As you can see in the MLO view in the posterior aspect or the upper part, there was a speculated mass and it's deeply seated. I think, yes, this one. It's not working. The deeply seated lesion in the MLO, it's not the distortion in front, but the mass in the posterior aspect. So it was somehow missed cancer because of the dense breast, so we have to do a proper evaluation for patient with breast regardless to the family history. Ultrasound for breast cancer detection. There was a study, a systematic review and meta-analysis published in Journal of Global Oncology in 2019. From the 26 eligible studies for inclusion, ultrasound had an overall pooled sensitivity and specificity 80 to 88% respectively. Low and middle income country data was considered in the studies. The invisibility of the mammography in certain setting, the results support the potential use of ultrasound as an alternative for mammography if not available for screening modality. Automated breast ultrasound, according to study, it shows that adding automated breast ultrasound to mammography is of a great value in detecting breast cancer in mammographic dense breast to increasing the detection rate in most of the cancer. 36-year-old lady with positive family history, mother at age of 45, ACRC, heterogeneously dense mammary parenchyma, baseline screening 2022, detecting an ultrasound small speculated mass. This mass was detected by ultrasound, and there was nothing to see on the mammography. Dynamic contrast enhanced MRI, contributing to the earlier detection of the breast cancer, particularly in women under the age of 40, whom mammographic sensitivity is less. Contrast-enhanced MRI has shown to have a higher sensitivity for detecting breast cancer in high-risk asymptomatic or symptomatic women. Women with personal history of breast cancer at a risk of development of local recurrence, the MRI will have a great value in evaluating patient to evaluate the recurrence from the post-operative changes. 39-year-old lady, history of left breast CBS. ACRB, scattered mammary parenchyma, the left upper outer parenchymal distortion in the MLO view. The dynamic contrast, it was given by RADS2 as a post-operative changes, but still the patient needed to do an MRI just to make sure there is nothing in the operative bed. Dynamic contrast MRI to assess the operative bed suspicious lesion, and it revealed recurrence at the operative bed. 42-year-old lady with positive family history, mother, patient receiving hormone replacement therapy. ACRB, scattered mammary parenchyma, routine screening, bilateral fibrocystic changes, dynamic MRI, being a high-risk individual, showed a suspicious upper outer breast infiltrating mass. So to conclude, for average risk women, annual screening, mammography at age of 40 with mammogram plus or minus digital tomosynthesis according to the dynasty. Maybe supplemental ultrasound, MRI is not recommended as we mentioned. In the high-risk women, annual screening at age of 30 by mammography and digital tomosynthesis. 8 years after the chest radiation, annual MRI for patient with a positive or genetic family history. Without teamwork, we would never be able to achieve the quality we have now. Thank you.
Now, Dr. Minette Allah Hanafi will give us a talk about contrast mammography by Red Lexicon. She's a lecturer of radiology, Women Health Unit, Qasr Al Aini, and a consultant at Bahia Hospital. Hope we'll all enjoy the lecture.
Contrast-enhanced mammography by Red Lexicon. Contrast-enhanced mammography was first approved by the Food and Drug Administration in 2011, and its use is increasing. Contrast-enhanced mammography has been shown to be more sensitive than mammography or ultrasound for detection of malignancy. Given that utilization is increasing, it's important that a lexicon be available to allow for consistency in reporting and also to allow for validation of standardized terms through studies looking at performance of contrast-enhanced mammography in a variety of clinical settings. The first version of contrast-enhanced mammography by Red Lexicon was released this year. Contrast-enhanced mammography lexicon includes indication, technique, and image acquisition parameter, breast imaging lexicon, and reporting system. The potential clinical indications of contrast-enhanced mammography are local staging of breast cancer, problem solving for inconclusive mammographic findings, monitoring post-neoadjuvant response, and high-risk screening. The usual dose of contrast, the technique of contrast-enhanced mammography, the usual dose of contrast media is about 1.5 cc per kilogram delivered at a rate of 3 cc per second. 2 minutes after contrast injection, a set of bilateral CC and MLO views is acquired. Each view consists of low and high energy exposure. The low energy image is obtained at a kilovolt in the range of standard mammography, generally 28 to 32 kilovolt, and the high energy image typically between 45 and 49 kilovolt. A post-processed recombined image is generated from low and high energy images. Breast imaging lexicon contrast-enhanced mammography. The lexicon for low energy image portion of contrast-enhanced mammography is same as mammography lexicon. For recombined images, terms are adopted from MRI section, but with some modifications. The lexicon starts with assessment of breast composition and background parenchymal enhancement. Breast composition should be assessed on low energy images and characterized using categories similar to conventional mammography. The report should include a description of breast composition using one of the following: ACR-A, almost entirely fatty breast; ACR-B, scattered fibroglandular tissue; ACR-C, heterogeneously dense breast; and ACR-D, extremely dense breast. The background parenchymal enhancement may be symmetrical, as in this case, or asymmetric. Regarding degree of background parenchymal enhancement, it may be minimal, mild, moderate, or marked. Findings seen on contrast-enhanced mammography will be classified into 3 main categories: those seen on low energy images only, and these lesions will be described according to mammography by Red Lexicon, and those seen on low energy image with associated enhancement on recombined image, and those presented as areas of enhancement seen only on recombined image with no corresponding finding on low energy images. Those presented as areas of enhancement seen only on recombined image may be mass, non-mass, or a new term enhancing asymmetry. The mass, regarding its shape, it may be rounded or oval, or irregular, while margin may be circumscribed, irregular, or speculated. Regarding internal enhancement of a mass, it may be homogeneous, heterogeneous, or RAM. The non-mass enhancement will be described according to their distribution and internal enhancement pattern. Distribution may be focal, linear, segmental, regional, multi-regional, or diffuse. The internal enhancement pattern may be homogeneous, heterogeneous, or clumped. Enhancing asymmetry is a new term added to contrast-enhanced mammography by Red's lexicon. It refers to an enhancing lesion seen only in one view, not in the other view. As in this case, an enhancing asymmetry is seen in MLO, but not seen in CC view. In MRI, it appeared as enhancing mass lesion, and biopsy was performed to reveal invasive duct carcinoma. Lesion conspicuity, whether it was lesion was mass or non-mass or enhancing asymmetry, is assessed. It may be low, which means equal or slightly higher than background parenchymal enhancement, moderate, or marked, or high. Abnormalities seen on low energy and recombined images will be described according to their morphology, extent of enhancement, internal enhancement pattern, or lesion conspicuity. Regarding internal enhancement pattern and lesion conspicuity will be described as those seen on recombined images only. Regarding morphology of abnormalities seen on low energy images and recombined image, the low energy findings should be described using Red's mammography lexicon. If the low energy finding that enhance is not a mass, asymmetry, architecture distortion, or calcification, for example, and the area enhanced, the characteristic of enhancement should be described using contrast-enhanced mammography lexicon. For masses seen on low energy images that also enhance, it's not always necessary to further describe the mass shape and margin as seen on recombined image. Regarding the extent of enhancement of abnormalities on low energy images and recombined image, it may be partially enhanced, completely enhanced, enhancement may exceed beyond lesion, or no enhancement. Reporting system. The low energy and recombined images should be described separately, and the final assessment should be based on the most abnormal findings on each of these components. Contrast-enhanced mammography report structure should include indication, technique of contrast-enhanced mammography, comparison with previous studies, description of overall breast composition, clear description of any important findings, assessment categories, and finally, management recommendation. Contrast-enhanced mammography assessment categories and management recommendation. Category 0 means incomplete, need additional imaging evaluation, ultrasound or MRI, or prior mammography for comparison to make final assessment. Category 1, normal study. Category 2, benign findings such as intramammary lymph node, implant, cyst, old non-enhancing scar or recent scar, post-operative collection, and fat-containing lesion. Category 3, a finding assessed using this category should have a less than 2% likelihood of malignancy, but greater than essential 0% likelihood of malignancy. Typical findings on mammograms that are appropriately assigned a probability line assessment are well established. For findings seen on recombined images only, there is still no data to guide which lesions fall into this category. Ideally, any finding or questionable finding should be fully worked up. Category 4, suspicious lesion. This category is used for findings that have more than 2% but less than 95% chance of malignancy, and for which biopsy is recommended. This biopsy can usually be performed by ultrasound or contrast-enhanced mammography or MRI guidance for lesions not visible at either ultrasound or mammogram. Category 5, highly suggestive of malignancy. This assessment carries a very high probability of malignancy. Category 6, biopsy-proven malignancy. This category is reserved for examination performed after biopsy-proven malignancy but prior to surgical excision. Limitations of the new contrast-enhanced mammography lexicon. The foci as a morphology descriptor is not used in contrast-enhanced mammography lexicon descriptor, although foci are commonly seen in contrast-enhanced mammography studies. An article with title, Can We Apply MRI by RAS Lexicon Morphology Descriptor on Contrast-Enhanced Spectral Mammography by my dear professors Dr. Rasha Kamal, Dr. Maha Hilal, and Dr. Sahar Mansour and their colleagues, concluded that multiple bilateral faintly enhancing foci are considered as morphology descriptors of benign breast lesions, while single unilateral or intense enhancing foci are considered as morphology descriptor of malignant breast lesions. Also, the lexicon add a new term, enhancing asymmetry, which in fact will be a mass or non-mass seen only in one view. The contrast-enhanced mammography lexicon removed dark septation, which is characteristic to fibroadenoma, from the enhancement pattern of mass lesions. Here in some cases, 50-year-old female patient came for screening. Her mammography and low-energy images revealed heterogeneously dense breast ACRC with left breast upper outer quadrant architecture distortion. Her recombined images revealed minimal background parenchymal enhancement with left breast upper outer quadrant heterogeneous focal non-mass enhancement with moderate conspicuity by RAS 5. Final diagnosis was invasive duct carcinoma. 59-year-old female patient came for screening. Her mammography and low-energy images revealed heterogeneously dense breast ACRC with right breast upper outer quadrant irregular indistinct mass lesion. Her recombined images revealed minimal background parenchymal enhancement with right breast upper outer quadrant multifocal irregular not circumscribed heterogeneous enhancing mass lesion with high conspicuity by RAS 4. Pathology was tubulobular carcinoma. 52-year-old female patient presented by right palpable mass. Her mammography and low-energy images revealed heterogeneously dense breast ACRC with right breast upper outer quadrant irregular indistinct mass lesion. Her recombined images revealed mild background parenchymal enhancement. The right breast upper outer quadrant mass shows heterogeneous enhancement with high conspicuity, and enhancement extend beyond the lesion in the form of heterogeneous linear non-mass enhancement. Pathology was invasive duct carcinoma. 45-year-old female patient with mastalgia. Her mammography and low-energy images revealed heterogeneously dense breast ACRC with right inner quadrant single-view asymmetry. Minimal background parenchymal enhancement was seen in her recombined images with right inner quadrant enhancing asymmetry. By ultrasound and MRI, right breast lower inner quadrant highly suspicious lesion by RAS 4, pathology invasive duct carcinoma grade 2. 40-year-old female patient with pathologically proven right breast cancer. Her mammography and low-energy images revealed right upper inner quadrant irregular indistinct mass lesion. The recombined images revealed minimal background parenchymal enhancement. The right breast mass show heterogeneous enhancement with high conspicuity by RAS 6, and left lower inner quadrant irregular not circumscribed heterogeneous enhancing mass lesion with high conspicuity by RAS 4. Final pathology was bilateral invasive duct carcinoma. 36-year-old female patient with pathologically proven left breast cancer. Her mammography and low-energy images revealed extremely dense breast ACRD with left lower inner quadrant irregular indistinct mass lesion. Contrast-enhanced mammography recombined images revealed mild background parenchymal enhancement. The left lower inner quadrant mass show heterogeneous enhancement and high conspicuity with lower outer quadrant multiple irregular not circumscribed heterogeneous enhancing mass lesion with high conspicuity by RAS 6. Final pathology was multicentric invasive duct carcinoma. Thank you.
Thank you. Now Dr. Dalia Al-Mesidi, assistant professor in Asr Al-Aini College and also consultant in Bahia Hospital, will give you a lecture about automated breast ultrasound, indication and interpretation.
Bismillah ar-Rahman ar-Rahim, automated breast ultrasound indications and interpretation. Mammographic screening is proven to reduce mortality from breast cancer through early diagnosis. However, its sensitivity is much reduced in dense breasts. And for this reason, breast density has been established as an independent risk factor for breast cancer, and the need for an additional tool has gained greater interest. So as mammographic density increases, its sensitivity to detect breast lesions decreases. Moreover, as the breast density increases, there's an increased risk of developing breast cancer. So what's special about automated breast ultrasound is that it provides volumetric image acquisition. This helps overcome some limitations of handheld ultrasound. It standardizes breast ultrasonography and avoids operator dependence. It has the ability to depict the entire breast in one image set and has a shorter time to perform. Automated breast ultrasound has a wider field of view and allows 3D reconstruction, in contrast to handheld ultrasound, which has the virtue of elastography and color Doppler evaluation. Automated breast ultrasound separates the time of image acquisition from the time of its interpretation. And as a result, it increases reproducibility, reduces operator dependence, and reduces exam time. The 3D reconstruction of breast tissue provides the advantage of multiplanar reconstruction with anatomic depiction of the whole breast from the skin through the volume of breast tissue to the pectoral muscles and underlying ribs. It has the ability to review images retrospectively after the exam has been acquired. The main indication for automated breast ultrasound is screening in the presence of dense breasts in asymptomatic women. However, there are no absolute contraindications. It can document multiplicity or bilaterality of lesions and can help estimate tumor extent precisely and monitor variations in tumor dimensions during the course of chemotherapy. The modern automated breast ultrasound machine received its FDA clearance in 2012. It's provided with a special high-frequency, large footprint transducer similar in size to a mammography compression paddle mounted on a mechanical arm. The advantages of the wide footprint transducer is having a much broader range of breast tissue covered within one scanning motion. The extended field of view allows the evaluation of multiple findings and a larger area of tissue surrounding a lesion. To perform the examination, the patient lies in the supine or supine oblique position with the arm of the side under examination either elevated over her head for the anterior and lateral scan and put at the side for the medial scans. A replaceable membrane covers the transducer surface and coupling lotion is spread evenly, which allows adequate contact with the skin of the entire area. The acquisition starts from inferior to superior after placing the probe over the breast with only mild compression. In most cases, 3 one-minute automated breast ultrasound scans of 1 minute each for each breast are obtained for a total of 6 acquired image sets, namely the interior, posterior, the lateral, and the medial positions. For larger breasts, additional scans are necessary to acquire complete coverage of the breast tissue, such as the superior and the inferior scans. After image acquisition, raw data are stored on the system's hard disk and then transferred to a dedicated workstation. Images are displayed in both the native axial plane of acquisition and reformatted coronal and sagittal planes. Images are then reviewed for further interpretation and analysis. The workstation's software used to interpret the images enables the physician to scroll through the image stacks of 3 orthogonal planes per view simultaneously as a cross-imaging study. The position of the voxel in each orthogonal plane is correlated and can be denoted by crosshairs. The coronal plane is the best for depicting the distribution of findings such as multiple masses imaged. Automated breast ultrasound has unique features of display, such as the retraction phenomenon, which is best seen in the coronal plane. It's a sign of malignancy, which presents as a stellate pattern around the lesion. The white wall sign, which presents as an echogenic wall in the coronal view and corresponds to the acoustic enhancement on handheld ultrasound. It's mainly seen with benign lesions such as simple cysts, fibroadenoma, and papilloma. The coronal view can detect non-mass lesions by depicting dilated ducts and intraductal echoes through their whole length. The skip artifact can be used to detect isoechoic masses. They present as a transverse anechoic line at the site of change in tissue stiffness due to MS. The limitation of automated breast ultrasound are exclusion of the axillary region from the field of view. It does not have tools to assess vascularity or elasticity and cannot perform ultrasound-guided interventions. Automated breast ultrasound can be applied through all stages of breast screening, from screening and detection to characterization to staging and follow-up. However, its application was initially focused on screening setting, especially in dense breasts. Adding automated breast ultrasound to mammography increased the sensitivity of detection. However, the specificity was not changed or even slightly reduced. And again, the recall rate was again increased. Comparing automated breast ultrasound to handheld ultrasound, it has a comparable detection rate. Some representative cases. This is a case of bilateral heterogeneously dense breasts where automated breast ultrasound could see a para-areolar area of altered parenchymal echogenicity, which was proved on pathology to be of malignant origin. This is another case showing a right lower outer quadrant small focal asymmetry, which was seen on automated breast ultrasound as an ill-defined, irregular, hypoechoic mass lesion, again proved to be malignant on pathology. This is a case of heterogeneously dense breast showing a left upper outer quadrant irregular focal asymmetry, which was again seen as an irregular hypoechoic mass with surrounding desmoplastic reaction and proved malignant on pathology. This is the last case of a heterogeneously dense breast where automated breast ultrasound could detect this malignant lesion, and that was proved to be malignant on pathology. So to sum up, automated breast ultrasound is an effective screening modality to detect mammographically occult breast cancers in women with dense breasts. Its diagnostic accuracy is comparable to that of handheld ultrasound. When added to screening mammography, it shows better sensitivity of detection, yet equivocal or decreased specificity. It faces some limitations, such as the absence of tools to assess vascularity and elasticity. Thank you.
And now for the next speaker, Dr. Shrihan Garir. 2 p.m. or not 2 p.m.? That's the question. Dr. Shrihan.
Good evening. The focus in most imaging modalities has been always directed towards achieving excellence in anatomic resolution and morphological imaging. So what we have when we look at mammography, including tomosynthesis, ultrasound, CT, and MRI, we see them as qualitative tests that detect morphological, non-specific tissue changes. Oh. To start again, 2 p.m. or not 2 p.m. In most imaging modalities, the focus has been directed towards achieving excellence in anatomical resolution and morphological imaging. So that what we see with mammography, including tomosynthesis, ultrasound, CT, or MRIs, that they are all qualitative tests that detect morphological non-specific tissue changes and do not allow the assessment and comprehension of breast cancer in all its diversity. With the discovery that breast cancer has a remarkable degree of morphological and molecular complexity, not only between tumors, but also among the same tumors, more emphasis has been placed on functional molecular imaging that is used to depict physiological and cellular processes such as altered vascularity or metabolism, so that what we gain is multiple and distinct anatomical, functional, and metabolic information from a macroscopic to a molecular level. These functional images include contrast-enhanced spectral mammography, MRI with all its weighted images, and the nuclear imaging, which includes SPECT, BCGI, and PEM. So what is PEM? How is it done? And why should we use it? Positron emission mammography, or PEM, is a relative new imaging modality that has higher resolution than PET-CT. It's focused on the fact that generally tumor cells have an enhanced glucose metabolism due to accelerated tumor growth, as well as an increase in glucose transporter proteins compared to non-malignant cells. It uses a short-lived radioactive sugar that is injected into the body to detect metabolically active lesions. This radioactive sugar accumulates in cancer cells in the breasts and emits high-energy positron radiation that is then detected and analyzed. The patient must be fasting for 4 to 6 hours prior to the test and should rest for about an hour after injection. The patient is seated and gently stabilized. Positioning is similar to mammography. The imaging process takes around 10 minutes per view with a total of 40 minutes, and usually starts 1 hour after the injection of the radiotracer with 12 sliced images reconstructed from each view. The three-dimensional tomographic image set provides a detailed location of normal and abnormal FDG uptake, as well as features or architectural patterns of any abnormal uptake. And these are the slices that we get at the end of them. It is particularly useful when other imaging results are indeterminate and has a complementary role to mammography, ultrasound, and MRI, and therefore can be used during the staging, during therapy, and during the post-operative period, and can also help in guiding breast biopsies. In the staging process of breast cancer, the primary benefit of PET imaging is that diseases such as cancer often manifest as disordered metabolism before anatomical changes can be seen. In very small tumors measuring less than 1 centimeter, the imaging sensitivity of PEM has been reported to be 60 to 70%. It can image the earliest in situ forms of breast cancer, as well as putative cancer precursor lesions, whose behavior is important for prevention studies. When PEM has been directly compared with PET and MRI, the sensitivity was comparable to MRI, and significantly higher than that of PET, particularly in small tumors. And some authors have demonstrated certain correlation between the degree of FDH uptake and several features of the tumor, including histological type and grade, cell receptor expression, as well as cellular proliferation index. An ideal goal for any molecular imaging approach would be to provide a map of the extent of both the invasive and non-invasive disease to assist the surgeon in undertaking more precise excision of the involved breast tissue. An advantage of the PEM technology is that it uses mammographic positioning, allowing direct correlation between PEM and mammography for both initial and recurrent imaging. Its tomographic images that it provides may also further assist the surgeon in determining the ideal approach to ensure negative margins. In the treatment of breast cancer, breast-conserving surgery is a standard operative procedure. To select the correct surgical procedure, it is necessary to diagnose the extent of the pathological changes within the breast to achieve a negative surgical margin. It is also critical to detect any cancer that is present in the contralateral breast. Concerns have been raised that MRI can be affected by the menstrual cycle, has several side effects associated with the use of conscious media, and cannot be performed in patients with internal metals or claustrophobia. And when compared to PET, PET demonstrates low sensitivity for small breast cancers of diameters up to 10 centimeters. And with the use of the PEM machines, the breasts are located on the body surface. The detector can be brought as close as possible Thus, proximity imaging allows breast PET to obtain higher, PEM, to obtain higher spatial resolutions than whole body PET CT. The detectors at the same time immobilize the breast to reduce respiratory movement, which has been successful in increasing detection sensitivity. The detailed image of the distribution of the FDG in the mammary gland can be obtained by scanning the breast for a longer time than the whole body PET. In a study by Tarafa et al. Involving 19 patients who were undergoing breast-conserving surgery, PEM correctly predicted 75% of patients with positive margins and 100% with negative margins. It also detected 4 out of 5 histologically proven incidental breast cancers, 3 of which were not seen by any other imaging modality. The authors concluded that PEM showed promise in detecting breast malignancies and assisted in planning breast-conserving surgery. And in this case, we have a digital mammogram and breast PEM imaging of DCIS. There's a vague asymmetry in the MLO mammogram in a 48 women with dense breasts. Stereotactic biopsy proved it to be DCIS. The PEM showed more extensive disease than was suspected in mammography, with segmental tracer uptake seen on the CC and MLO views. In a study by Berg et al., PEM accurately identified 91% of the cases of DCIS preoperatively, which was a higher value than obtained by MRI. In this case, we can see how PEM can distinguish a silicon rupture from a mass. In the left MLO mammogram, in the 65-year-old woman shows a retroglandular silicon implant that has ruptured with extracapsular silicon obscuring most of the tissue. A larger mass is noted just above the implant. And the MLO in the PEM in the right images shows intense uptake in an irregular mass, as well as uptake in one axillary lymph node, which has been included on the image, the red arrow. And the final pathology was a DCIS, about this 5 centimeter IDC with 8 metastatic lymph nodes. In this case, there's an enlarging right breast with nipple retraction and skin dimpling. There was a negative mammogram, ultrasound, and MRI. PEM was performed for further evaluation, and it revealed uptake in the right breast tracking toward the nipple. The biopsy was positive for invasive lobular carcinoma. In this case, we have a 34-year-old female with bilateral breast implants. She presented clinically with 3 palpable lumps in the left breast. The mammography and ultrasound confirmed 3 questionable masses with associated microcalcifications. Whole body PET CT showed uptake in the left breast and axilla. PEM done to define the extent of the disease, it showed clearly 3 lesions and 5 suspicious axillary lymph nodes suggestive of local regional metastasis. Biopsy was done, and this confirmed invasive ductal carcinoma. In this case, it's a 42-year-old with extremely dense breasts. She was high risk with positive for the gene mutation. She was unable to undergo breast MRI due to claustrophobia, and PEM was recommended as an alternative, and it identified a suspicious area of uptake in the right breast. Biopsy confirmed grade 3 invasive ductal carcinoma. This case shows pleomorphic calcifications in the retroareolar regions. PEM was positive in the region of interest, and the biopsy was high-grade invasive ductal carcinoma as well. Its sensitivity and small lesion detection, when compared with MRI, it had a higher sensitivity in cases of DCIS and in T1A stages. However, PEM still suffers from the same specificity issues as those seen in breast MRI. Its specificity for detected carcinoma ranges from 85 to 92. This is regards to MRI, and from 92 to 97 for the PEM. A number of non-malignant lesions can accumulate the radiotracer, such as fibroadenoma, fibrocystic changes, and fat necrosis. And to address this issue, commercially available biopsy systems can be used, which allow vacuum-assessed biopsy of PEM-detected lesions prior to altering surgical management. The predictive value of these biopsies have been similar to those seen for MRI-guided biopsy and higher than that seen for mammography. During the procedure, the patient is placed in an upright position. It's easier than MRI for patients with severe back problems, and there's no associated claustrophobia. These images show that how it can clearly visualize the lesion. The lesion can be targeted, and it confirms the removal with further confirmation with a post-biopsy specimen scan. This shows the ability of PEM to help ensure a breast biopsy is taken in the best location. The most metabolically active tissue needs to be evaluated for malignancy. In the cases of nodal involvement, it's too early to determine the sensitivity and specificity with using the PEM technology. However, some commercial sites are obtaining useful images of lymph node involvement. It's still difficult in identifying small volume nodal disease. However, with improvement, this could mean more sentinel lymph node dissections and fewer axillary lymph node dissections. When it comes to therapy in breast cancer, the greatest needs in neoadjuvant therapy is to find an early and accurate way to determine the responders, thus avoiding high costs and toxicity that's unnecessary and allowing the change to a more effective treatment. This is the central concept of personalized medicine, thus the increasing interest in functional imaging. The FDG tumor uptake generally decreases during and after chemotherapy, and any residual tumor uptake after completing the neoadjuvant chemotherapy predicts residual disease. Numerous studies have shown that changes in tumor glucose metabolism during therapy are significantly correlated with final response and patient outcome and is highly predictive of relapse. There are new tracers that provide specific information on tumor characteristics, including proliferation, hypoxia, or perfusion, as well as receptor expression that are being developed. These images demonstrate the ability of PEM to quickly assess response to chemotherapy as early as 1 week after the first cycle. In the post-surgery setting, because of its high sensitivity in the detection of metabolically active disease, it can help when recurrence is suspected. It's particularly true in the evaluation of anatomical regions that have been previously treated by surgery or radiation, where the discrimination between post-treatment scar and recurrent tumor can be problematic. Earlier recognition of recurrent disease will hopefully provide more effective treatment options and improve survival in this group of patients. Will the use of PEM imaging for routine surveillance in women treated for breast cancer allow detection of local regional recurrence at an earlier stage, and if detected earlier, could earlier therapy prevent or decrease the incidence of cancer metastasis? This is a question that should be answered. The following slides, I'll be reviewing some cases done by Dr. Sara Sa'ar as part of her thesis. They were done in Bahia. And case 1 is the clinic shows a 48-year female who came to perform her annual screening mammography in Bahia and with no specific complaint. The mammography revealed a left breast lower quadrant developing asymmetry. And the PEM showed the left breast multicentric FDG avid scattered malignant masses and foci. The PUV max was 3.6 and the ratio was 8.6. The lesion to background ratio was 8.6. The final diagnosis, there was left breast multicentric IDC and micropapillary carcinoma with high-grade DCIS, and the patient underwent a mastectomy. In this case, it's a 40-year-old female who performed sonomammography complaining of right breast swelling and induration. The mammography and ultrasound revealed right breast edematous changes, and she had previously done an MRI outside Bahia, where we had no images, and it was reported as only edematous changes. The PEM revealed right breast upper outer quadrant peripheral FDG avid region with an PUV max of 1.96 and a ratio of 4.3. The patient also underwent a mastectomy for right breast infiltrating pleomorphic lobular carcinoma. And this is a case of a 40-year-old female who came complaining of right breast palpable lesion. The ultrasound and mammography revealed breast subtle global asymmetry, and ultrasound detected at 10 o'clock ill-defined irregular lesion of mixed echogenicity. The right breast upper outer quadrant showed multifocal FDG avid lesions on PEM, and they had a PUV max of 9.6 and a ratio of 11.4. The patient also underwent a mastectomy for right breast multifocal IDC with major DCIS. In this case, the patient came complaining of right breast body nipple discharge. The mammography and ultrasound revealed an upper outer quadrant dense irregular mass, as seen by ultrasound as a 10 o'clock area of parenchymal distortion. On PEM, the right breast revealed upper outer quadrant and lower outer quadrant mass and non-mass uptake. The diagnosis was, post-biopsy diagnosis was breast multicentric invasive ductal carcinoma with lobular differentiation. In this case, we have a 62-year-old female who presented with left axillary palpable lesions. The mammography was free, was given a BIRAD 0. Ultrasound revealed a left axillary pathological lymph node. The PEM only showed small focus that showed faint FTG uptake. It had a low PUV maximum value of 0.9. And the biopsy revealed low-grade pure DCIS. The patient received neoadjuvant chemotherapy and then performed a mastectomy. So do we need another imaging modality on the breast imaging team? It has been shown that molecular imaging has the advantage of not being dependent on capillary angiogenesis. So that's why tumors can be discovered at an earlier stage than MRI and at an earlier stage than mammography. It has the advantage that claustrophobic patients can perform it. It has no contrast reactions. It can be done with patients with renal disease, with metal implants, should not be affected by the menstrual cycle, and is biopsy capable. However, there are some limitations to PEM, and these include a radiation dose that is higher than that of a mammogram. It is higher than that of a tomosynthesis and higher than that of MBI. However, the American Association of Physicists in Medicine say that the risk of medical imaging at effective doses below 50 for single procedures or 100 for multiple procedures over short periods are too low to detectable and maybe non-existent. And this means that the examinations should not be stopped or prevented. There's also high risk of urinary bladder cancer because that's where the tracer accumulates the most. It could be confusing in hypermetabolic lesions. This is also a case done in Bahia where there was confusion of whether this was a malignant lesion or at the end it turned out to be inflammatory. Visualization of tiny lesions in a voluminous breast may be challenging. It has lower sensitivity in invasive lobular and low-grade DCIS. There's potential difficulty in imaging breast lesions that are in a posterior location, the variable uptake of FDG in small and less metabolically active tumors, and the false positive findings from prior biopsy. What are the implications for patient care? It could be an alternative for women who cannot tolerate MRI. It has improved specificity compared with MRI, and is therefore likely to prompt unnecessary biopsies. Review of mammograms together with MR or PEM images or both improves the detection of additional disease. It is a promising functional tool to predict true functional metabolic response of breast cancer to neoadjuvant chemotherapy, helping to ascertain final tumor burden, which is a pivotal prognostic factor in breast cancer patients. Breast cancer is a common disease in women and a leading cause of death. As breast cancer diagnosis and therapies become increasingly molecular and individualized, molecular imaging will play a progressively more important role in breast cancer clinical care. They offer exciting potential to translate tissue-based genomic discoveries to the clinic and to further the development of more therapeutic agents for breast cancer. The introduction of new positron-emitting imaging agents, such as the cell proliferation markers or other radiotracer marker for tumor hypoxia, offers new opportunities for evaluating breast cancer and might help to achieve this goal. PEM is bringing us closer to personalized cancer therapy. Thank you. Just as a final note, I'd quickly like to ask Dr. Rasha Kamal about the experience of PEM in Bahia. So can we give the mic to Dr. Rasha, please?
Yes, thank you, Sherry.
Hello, Dr. Rasha. I just wanted to ask you, when was PEM introduced to Bahia? When was it installed, and how many cases were performed?
About 3 years ago, yes.
And how many cases were performed? Around how many cases?
Up till now, I think 330, 350 cases, like something like that. Yeah.
And in your opinion, which is the best clinical scenario for it to be used?
Actually, there is no alternative when the patient has allergy or she has renal impairment. To contrast media is contraindicated in these cases, and it is our only available modality in these cases. We are doing some studies to test it in the follow-up of neoadjuvant chemotherapy because it's not a qualitative assessment. You know that sometimes the tumor mass does not decrease in size, but it is actually responding. So it gives us quantitative and qualitative information. This study is ongoing. In some cases where MRI was always accused of having a low specificity because of additional enhancing lesions which turn out in the post-operative pathology to be nothing. It decreases the number of false positive cases that we see on MRI.
And has it been very confusing in any cases? Do you think it should
It
not
is,
be
it
used
is,
with
yes,
specific?
Yes, in the inflammatory lesions, MRI is much superior.
Okay.
In the post-operative, up till now, there is no proof that يعني patients receiving irradiation or immediate post-operative MRI is much better.
Okay.
Although in the literature they say that we should not perform MRI in the post-operative, the immediate post-operative MRI is very valuable whenever you get positive margins. It's the only modality on which we can depend to identify residual disease. In these cases, PEM will give us false positives. Okay. And it's not like MRI. We have multi-sequentials to look at the lesion in the T2 and in the T1 to know if it's, for example, fat necrosis or a collection. Everything we will see uptake, but you will never be definite that this uptake is due to an inflammatory process or. And of course, what you said at the end in the DCIS and the lobular, it is still. You have to perform more studies because the uptake in the lobular and the DCIS is much lower than expected for malignant tumors.
But you think at the end it's a good addition to the...
It helps us in a lot of cases,
Thank you.
Yes.
Thank you.
Thank you, Dr. Shrihan, for the nice presentation. Now we will go to last speaker, Dr. Sarah Muhammad, a clinical leader in GE. She will talk about contrast-enhanced mammography biopsy.
Good evening, everyone. Thanks for giving us the chance to be with you today, presenting the contrast-guided biopsy. Before we start, although we're going to discuss the biopsy, I thought of revising the contrast technique in one slide. Contrast mammo is done by injecting contrast media, same as CT protocol, waiting for 2 minutes and just taking regular mammography images. And then we'll get 2 sets of images, the low energy, which looks like a normal mammo image, and the recombined, which gives the contrast uptake. This is the diagnostic setting, but what about interventional setting? In some cases, the lesion is very small. It's very challenging to see it under ultrasound, and the only way to take it is under contrast technique or under contrast guidance. الحل الوحيد قدامنا كان MRI. But this is time consuming, this is costly, ومش كل الأماكن عندها MRI biopsy، وساعات بيبقى busy waiting lists. GE كانت أول vendor يقدم أو أول شركة تكنولوجي تقدم الكونتراست مامو، و complementary solution هو الكونتراست guided biopsy. we launched it. والستاديز بينت إن الكوست بتاع الكونتراست مامو almost الهاف، والتايم حوالي 15 minutes comparing ل 60 to 90 minutes لو أنا بعمل MRI. الكونتراست جايدد بايوبسي تكنيك لازم اكون انا اصلا متعوده اعمل كونتراست مامو، واكون متعوده كمان على الستيريوتاكتيك بايوبسي، وهي ستيبس مور اور ليس ذا سيم اكسبت ان انا بعمل بلاننج للليجن بتاعي الاول علشان الحق اخد البايوبسي قبل الواش اوت. بعد كده بانجكت عادي زي الكونتراست مامو العادي، وبعمل كومبريشن بتارجت باخد السبيسيمن وبعدين بحط الكليب. الديزاين بتاع السيرينا برايت اخر ديزاين لينا للكونتراست جايدد ستيريوتاكتيك either 2D او 3D او كونتراست جايدد. باقي بيركب الحاصل اقل كتير من المودلز اللي قبل كده. بقدر اسويتش من الفيرتيكال للهوريزونتال بالتيرن اوف نوب، واقدر اسويتش من ال 2D لل 3D للكونتراست، والعينه under the same compression and under the same examination. انا مش مضطره ان انا ادي كومبريس العينه او اخد اكسبوجر تاني. under the same compression اقدر اروح من الفيرتيكال للهوريزونتال. انا عايزه جو باك معلش. هو بيقلب اوكي تمام اوكي. under the same compression اقدر من الفيرتيكال للهوريزونتال ومن ال 2 دي لل 3 دي للكونتراست. يعني لو عايزه ابص على الكليب بعد ما اخلص خالص اقدر اخد 3 دي سويب. يبقى again الكونتراست جايدد بايوبسي انا بعملها لو حاجه مش قادره اشوفها بالسونار زي فيري سمول نوديول او ماس انهانسمنت مش قادره اشوفه بالسونار. دي one of the very first cases اللي اتعملت. كانت رايت اي دي سي نون رايت اي دي سي بس البيس لاين مامو باين نوديول على الليفت سايد. الفيرست attempt was to take this nodule under ultrasound. however لما جم يبصوا عليها على المامو تاني لقوا الكليب بعيد جدا. therefore the doctor decided ان هو ياخدها تحت ال CSM guidance. الام ار اي باين النوديول الثانيه وتحت السي اس ام طلعت invasive lobular carcinoma on the left side. التكنيك يعني بعمل ستيريوتاكتيك بايوبسي 2 دي بايوبسي عادي باخد السكاوت وباخد البلس 15 والماينس 15. بقدر اتوجل بتوين اللو انرجي والريكومبايند. بشوف التارجت بتاعي بعلم عليه بسلكت النيدل والبوزيشنر بالكوردينتس بيروح دايركت للمكان اللي انا عايزاه. بحط النيدل باخد السبيسيمن وبعدين باخد البري فاير بوست فاير باخد السبيسيمن واحط كليب. ودي طلعت invasive lobular carcinoma. دي حالة تانية 78 years female كانت حاسة palpable mass وما كانش في حاجة باينة بال 2 دي وال 3 دي مامو. عملت ام ار اي بان الماس الاولانيه هوفر بانت نوديول تانية وبالسونار ما كانتش باينه. البيشنت كانت اولد ايج فشي couldn't tolerate الام ار اي. برضه كانت ديسيجن ان احنا نروح للكونتراست جايدد بايوبسي واتخذت انتر كونتراست جايدنس. اجان احنا بناخد الزيرو بلس 15 وماينس 15. بنقي التارجت بسلكت النيدل باخد السبيسيمن وبحط الكليب. آخر حالة دي young patient وكان عندها برضو ماس وكان الحل due to the young age ان هي تروح للام ار اي بايوبسي بس كان الجهاز بيزي فكان القرار ان احنا نعمل سي اس ام بينت الليجن اجان ما كانتش باينه بالسونار. بعد 48 hours عملنا الكونتراست جايدد بايوبسي اتخذت اندر كونتراست جايدنس بنفس الطريقه وطلعت انفيزيف داكتال كارسينوما. تو سام ات اب احنا زي ما قدمنا الكونتراست مامو اول حد قدمه جي اي احنا اول حد برضو بنقدم بقيه السولوشن ان احنا زي ما قدمنا الكونتراست ستادي بنكمل السولوشن بان احنا بنقدم حاجه ناخد بيها البيوبسي لو مش باينه غير تحت الكونتراست. comparing للام ار اي هي less time consuming 15 دقيقه comparing ل 60 او 90 دقيقه بالام ار اي. less time consuming less costly والindications of MRI guidance. الظريف ان يعني زي ما قلنا الباقي سهله جدا الليرنينج كيرف سهل واقدر ان انا شفت من ال 2 دي لل 3 دي بايوبسي للكونتراست جايدد بايوبسي ومن الفيرتيكال للهوريزونتال من غير ما اضطر ان انا افك العيانه او ان انا اخد اكسبوجر تاني. طبعا يعني we're proud ان احنا الفيرست انستليشن في بهيه للسي اس ام بايوبسي في مصر. ميرسي يا دكتور. بالظبط هي 50% كوست داون 15 دقيقه فيرسز بالتالي اكتر دلوقتي 15 دقيقه فيرسز 90 دقيقه والليرنينج كيرفز يعني سهل يعني ظريف بالذات لما كان يعني زي ما هي هو اكسبيرينسد في الكونتراست ستاديز وفي الستيريوتاكتيك فده كان مسهل كمان الكونتراست جايدد بايوبسي يبقى الليرنينج كيرف سهل.
لا هي في الحالات اللي ملهاش الترا ساوند كوريليت يعني فعلا مفيد جدا جدا.
وهو ده المين انديكيشن دكتور لو يعني حاجه صغيره قوي انا مش قادره اشوفها بالسونار او ماس انهانسمنت مش قادره اشوفها بالسونار يعني الحاجه اللي مش قادره اخدها بالسونار تشالنجينج كيسز.
بالظبط كده ان شاء الله.
ثانك يو سو ماتش وشكرا على وقتكم.